Good evening, everyone, and welcome to our second day or session of our 14th Annual Research Scientific Conference of the University of the West Indies School of Clinical Medicine and Research, Bahamas. Our today's sessions will be about community health and family medicine. And we have some wonderful research papers that will be presented and two keynote speakers. We will start with our first keynote speaker for this evening, Dr. Kalei Philippe. Dr. Philippe is a senior medical officer in the Ministry of Health, Bahamas, and she serves as the focal point for a climate resilient health system. She is currently also the director of the Department of Public Health in the Ministry of Social Services and Urban Development. She is a member of the Stem Cell and Ethics Committee and the Medical Research and Oversight Committee for the Ministry of Health, Bahamas. She believes in mentoring youth and upcoming physicians to take their rightful place in creating change in their environments. Her key areas of interest include health systems improvement, monitoring and evaluation, gender-based violence, and climate change, and health and disaster management. She has conducted research in these areas and published several papers. This evening, we are honored to have her speak to us today on retrospective case series of COVID-19 healthcare workers in the Bahamas, March through April 2020. Let's listen attentively as our keynote speaker, Dr. Kalei Philippe, starts off our session this evening. Let's welcome Dr. Philippe.
Thank you so much. Apologies for that. So yeah, I want to thank the committee for allowing us to present this information. We're going to be looking at retrospective case series of positive COVID-19 healthcare workers in the Bahamas between March and April 2020. I want to thank my colleagues up front, Dr. Teoria Murray, Dr. Isaiah Roll, Nurse Peggy Cooper, Mrs. Camille Nairn, Dr. Philip Swan, and the surveillance unit in the Ministry of Health. This presentation was provided to the Health EOC, Emergency Operating Committee on the 20th of May 2020, and we have augmented it for this time. As we know, the spread of any emerging novel respiratory pathogen is accompanied by uncertainty because we don't know the key epidemiological, clinical, or virological characteristics, particularly in its spread. This coronavirus was similar. So I and my colleagues have no financial disclosure or relations or conflicts of interest with the presented material in this presentation. I want to submit to you the introduction, the literature review, methodology, results, and discussion surrounding this work that we did. Let's start with the Ministry of Health Emergency Operating Committee. As we sat every day looking at the transmission chains, we recognized that there was a transmission chain among the healthcare workers in the Bahamas. You would note the red circle. This was presented on May 13, 2020. There were 21 healthcare worker cases at that time. The circles, the blue circles identify males and the red circles identify females. Those that are colored have been recovered and those with gray had passed. So then we started to look at what was happening globally. We recognize in larger countries, France, US, China, Italy, and Spain, that they too were seeing a percentage of healthcare workers cases. But note that France reported only less than 1%. Even China had a low number of 3.8% out of almost 1 million cases. We were compared to Spain and the UK. And studies showed that the reasons why healthcare workers were being impacted because they lacked PPE and they weren't testing. We then looked at the regional data provided by PAHO and WHO, which looked at countries in the region. And you would see the red arrow that the Bahamas fell between Mexico, that had a population of 129 million, and Costa Rica, with a population of 5 million at 20%, about 24%, because we had 20 cases at that time. And this was from a line listing of almost 630,000 cases in April of 2020. We then determined we needed to describe the experience of healthcare workers who had been diagnosed with COVID-19 in the Bahamas and to evaluate for common trends. Our objectives was to characterize the range of clinical presentation of the infection and the risk factors among healthcare workers, to describe the infection prevention and control measures and practices as well, and to characterize the duration and severity of associated disease. In this presentation, we'll just look up at objectives 1 and 2. In our literature review at the time, we recognized that there were only case series among healthcare workers, and those particularly were associated with SARS outbreak of 2003. We know that other coronavirus, such as the Middle East respiratory syndrome, had been characterized by amplification events in healthcare settings, which would occasionally result in large nosocomial outbreaks. This was recognized by overcrowding in emergency rooms, non-adherence to IPC measures, and possible environmental contamination thought to be implicated. So therefore, we recognized that we needed to see what the studies showed and how that would impact us. We were able to identify 4 particular articles during the time, a cluster of cases in Toronto, healthcare workers. There were 17 who were reviewed from 6 hospitals. And the concerns that they identified were deficits in the formal infection control training, challenges and PPE use during the donning and doffing procedures, inconsistent use of masks, and fatigue. That was in 2020. There was another study done in Singapore, which looked at contact tracing of 41 healthcare providers who were exposed to aerosol generating procedures for at least 10 minutes. 85% of them were exposed, even though they were wearing surgical masks and N95 masks. And the conclusion from that study was that N95 masks or equivalent could prevent influenza infection among healthcare workers. We then move on to China in March 2020. They did a study looking at the reasons for healthcare workers becoming infected. This was a larger population, over 2,000 healthcare workers, 90% in the Hubei province in China, only reported 22 or 1.1% death. And their reasons for such high numbers of healthcare workers that were infected was they recognized that there were inadequate PPE at the beginning of the epidemic, that healthcare workers did not understand the pathogen well, and awareness of personal protection was not strong enough. There was an increased risk of healthcare workers because of prolonged exposure, large number of infected patients. And thirdly, the probable infection of healthcare workers due to pressure of their management of cases, the work intensity, and lack of rest. So we move to the methodology and results. So we decided that we needed to do, because of our small sample size, a retrospective case series of all identified laboratory confirmed infected healthcare workers in the healthcare facilities between March and April of 2020. Therefore, this study population were RT-PCR laboratory confirmed healthcare workers, and we were able to survey 20 out of the 21, which provided a high response rate. Of course, our eligibility criteria inclusion was all COVID positive healthcare workers in the Bahamas, and exclusion were all those who had either died or declined to participate in the study. The data collection instrument was developed from the WHO assessment of potential risk factors for 2019 novel coronavirus infection among healthcare workers in healthcare settings. And so we reviewed that document and then augmented it. Our data collection procedure involved a phone survey instrument. We developed a phone script, and time was reviewed by the team for cultural context and understanding of the questions. There were 4 interviewers, 3 primary and 1 secondary interviewer. We got the list of the lab confirmed healthcare workers from the surveillance unit. Verbal consent was obtained. Primary interviews conducted by a first phone interview, and there was a secondary interview. The responses were entered on the phone survey paper form, cross-examined by a second interview, and reviewed by the team, finally by the principal investigator for input into Excel. Our epidemiologists in the Ministry of Health reviewed the Microsoft Excel. Analysis was performed by SPSS. And we did descriptive statistics of quantitative variables and frequency distributions. Results are presented in percentages or whole numbers because of the small counts. Well, in terms of the expected outcomes, the data collected from the questionnaire was expected to shed light on some epidemiological data, including the profile of healthcare workers infected, the range of exposures, the use of infection and prevention control measures, the use of personal protective equipment, the spectrum of clinical symptoms, and duration. So going straight to the demographics. Our population had about 75% female, age range between 20 to 60 years. 85% were nurses, PCTs or physicians. And they came from both the private sector, 55%. There are a few who worked in both private and public, 10%, and 35% from the public sector. So what were the potential exposures? Well, healthcare workers self-reported COVID-19 exposure primarily from patients, secondarily from, they didn't know, travel, and then their social setting. What were their general infection prevention control standards and their use of PPE? Well, you would be happy to know that the vast majority reported that within the last 2 months or a year, that's 13 out of 20 reported that they had had some exposure to training, 4 were unable to recall, 1 had no training. In terms of adherence to standard IPC precautions, 16 identified that they always adhered to the precautions, 3 most of the time, 1 didn't know. Were there sufficient PPE in healthcare facilities during the time? Well, 65% of those surveyed said yes, 30% said no, and 5 were unsure. What percentage of healthcare workers reported they followed the hand hygiene practices? If you look at the first column, which is always recommended, between 80 to 95% said they followed the recommended practices before touching patient, before cleaning out. They did aseptic procedure after body fluid exposure and after touching patients. Only 65% said that they practice hand hygiene after touching the patient's surroundings. So what about specific adherence to IPC standards and PPP use? And this is really where we got most of our interesting information. In terms of healthcare workers' exposure to patients infected in 2019, those who had close face-to-face contact or were engaged in aerosolizing procedure, patient body fluids, patient materials, and surfaces around the patient, we're going to learn what was the response. So those that said they had close contact, which is 45% reported face-to-face, which is more than 15 minutes of exposure to a patient. And 70% of those said yes, they did have close contact. Only 30% said they had multiple contact with patients. In terms of close contact and personal protection use and hand hygiene, what were the type of personal protection equipment that persons reported using? 45% said they used gloves. Only 15% said they use medical masks, 10% gown. No one at that time reported that they were using a face shield, goggles, coverall, head cover, or shoes. And in terms of infection and prevention control practice, 50% performed hand hygiene before and after removing glove, and only 50% used alcohol-based hand rub and soap and water. What about those who were exposed to aerosolizing procedures? Only 3 out of 5, which is 15%, said they were exposed. And the procedures they reported being exposed to: nebulization, if they had to participate in a code, sputum induction in kidney dish, or swabbing. And the types of PPEs worn during those procedures, you would see only 3 reported using a N95 and 3 reported using gloves. No one reported using a face shield, goggles, coverall, head cover, or shoe covers. How about healthcare workers' contact with patients and body fluids? Well, 20%, 4 or 8, said they were exposed to saliva, sputum, or feces, and only 4 persons reported using gloves, 3 respirator, 2 medical masks. And they didn't use face shield, goggles, glasses, gown, coverall, head cover, or shoes. So how about contact with patient's material? Well, more of our healthcare workers said they were exposed to the linen, medical devices on the patient, personal items, clothes, or equipment connected to the patients. And in terms of contact with body fluids via the patient's materials, 15% said yes, they came in contact with urine, but only 2 reported wearing PPE and 3 reported only wearing gloves. So what about direct contact with surfaces around the patients? Yes, 50% of healthcare workers reported that they did have contact with the examination bed, the bathroom, the corridor, the doctor's table, more than one time. 35% reported more than one time, and 30% said they had no contact with bodily fluids via surfaces. But note, in the pink box, none reported wearing PPEs, and only 1 person reported practicing hand hygiene. So what about pre-existing conditions and symptoms in this population? Well, when we look at the number of healthcare workers in the percentage, 50% reported obesity, 20% having diabetes, asthma, hypertension, and other chronic conditions. When we look at the male to female ratio, the majority of female reported obesity, and it was 50% of those who reported having diabetes. So grouping of pre-existing conditions, we wanted to find out, did our healthcare workers have more between 0 or 1 or 2 or 3 pre-existing conditions? And we were able to determine that about 13 of the healthcare workers, 65%, had 0 to 1 pre-existing conditions, whether it's asthma, obesity, or hypertension, diabetes. What about the number of healthcare workers who reported having symptoms? About 45% reported having more than 6 symptoms. 40% reported 1 to 6 symptoms, and a few said they had no symptoms at all when it came to COVID-19. What were some of the symptoms reported by healthcare workers? Well, majority reported respiratory symptoms, fever, malaise, headache, fatigue, loss of appetite, chills, loss of taste, and others. Only a few, 25% reported having anosmia. So what about the number of symptoms versus the number of pre-existing conditions? So this slide tells us that in yellow are those persons who have no symptoms, although they might have pre-existing conditions. Blue, those who had 1 to 6 symptoms and pre-existing conditions. And those in the green had greater than 6 symptoms and had pre-existing conditions. So among healthcare workers with pre-existing conditions, 28.6% had 1 to 6 symptoms. The majority said they had more than 6 symptoms. So for discussion. So findings from this study, we were able to identify possible exposures and transmission of COVID-19 in healthcare workers, whether they were within the healthcare setting. We noted most people were exposed. The number of healthcare workers within a facility who identified possibly providing care to suspected confirmed cases. The number of healthcare workers identified healthcare facility and the types of roles they have, and the number of healthcare workers who practice IPC measures, their perception, and the number of healthcare workers with pre-existing conditions. So summary of the key points, 95% said they received IPC training. 80% always adhered to IPC standard precautions. About 80% had formal PPE training. 65% had PPE available in sufficient quantities in their healthcare facilities. 40% had IPC training in the last 2 months. Although 45% had face-to-face contact more than 15 minutes, none had on the full PPE protection, 50% only performed hand hygiene before and after removing gloves, and 50% used alcohol-based hand rub and soap. We note that training in IPC and PPE use in the Bahamas were done both in the Public Hospital Authority and in the Ministry of Health and Department of Public Health. We note that almost 2,000 staff, the A&E, EMT physicians, nurses, and general areas have been trained. And in terms of the Department of Public Health, about 251 nurses, PCA and TCN, have been trained in these practices. So what about policies and practices limitations? Well, we note that the IPC measures and IPC training were for suspected in contact with a laboratory confirmed case of SARS or COVID-19. Thus, they only considered symptomatic persons entering healthcare facilities, instead of looking at IPC measures to address asymptomatic and pre-symptomatic condition and transmission. Also, implementing source control for everyone entering the healthcare facility, whether they were patients or visitors, regardless of symptoms. As you remember, during the initial COVID-19, it was suggested that only persons who were symptomatic could transmit COVID-19. What we did not account for were those who were asymptomatic and transmitting. We know that in terms of the response to functions, the functions for the response of COVID-19 in hospitals or healthcare facilities, according to PAHO, involve these 10 areas, of which I have starred the infection and prevention control and information. These other areas are definitely significant: leadership, coordination, logistics and operation, administration and finance, rapid identification, diagnosis, isolation, and case management. When we look at the WHO standards for infection prevention control, there are 3 areas: limit human-to-human transmission, reduce secondary infections, and prevent transmission through amplification and super spreading events. And we noted that the STAR shows that initially we were thinking, oh, well, only COVID-19 was spread by droplets, airborne, not really. And remember the period of time when we didn't wear masks, right? So when studies continued and we recognized that they were airborne, then it was recognized that they were more susceptible individuals to direct contact and indirect contact in a hospital care setting. We noted the COVID-19 personal protective equipment, hand hygiene needed to always be performed despite PPE use. We needed to remove and replace any damaged or broken pieces, remove all PPE and discard all items. So these recommendations needed to be put in place regardless of a patient had symptoms. Conclusion recommendations. Limitations to the study was recruiting bias. Of course, we had a very small sample size, recall bias, reliability, and validity. We were unable to assess the healthcare facilities' policies and practices. We did not have a comparison with a control cohort for comparison of practices and experiences. We were in the process of completing that study as well. We recommended enhancing the IPC guidance to specifically address asymptomatic and pre-symptomatic transmission, to review all IPC materials from healthcare training units and independent providers to ensure standardized inclusion of PAHO WHO content requirements, also to ensure that there's monitoring and evaluation, a walkabout, and open reporting in healthcare facilities, and to review the healthcare facilities' IPC training and management plans. For future research, we suggested prospective risk analysis of public healthcare workers identified as contacts, assessment of healthcare facilities, and a serum testing on day 1 and day 21 of positive healthcare workers. We also suggested assessment of perception and education versus on-the-job action of healthcare providers. We want to thank all the healthcare workers who are on the front lines of this coronavirus pandemic. Noting all heroes don't wear capes, and we thank all of our colleagues, even our fallen heroes. Acknowledgement, of course, goes to the Ministry of Health, COVID EOC, the Pan American Health Organization of the Bahamas and Turks and Caicos Country Office, and Dr. Colette Cunningham-Myrie, the epidemiologist who assisted us in this work.
Good evening, Dr. Philippe.
Yes, ma'am.
Thank you for such an interesting presentation. I was wondering whether you thought that your data might be able to capture or ask the question of whether the remoteness of the IPC training of the healthcare workers
Mhm.
is able to impact the whether it shows how their practices change.
That's a really great question. Because we did a retrospective, it might be difficult to do that association. What we did note was that the IPC training that they got at the time was based on symptomatic cases. And we believe that could have been the reason why more healthcare providers were impacted, because the science had not caught up with us in terms of asymptomatic patients can transmit COVID-19 and patients should be wearing masks. Because we were able to do this quick study, it really then impacted the IPC measures in the hospital and healthcare facilities. And then you would have seen more people donning and doffing and wearing masks during that time. What you're also talking about is something that PAHO recognizes. When we do training, training needs to be close enough to the practice. So someone who would have done IPC a year ago, or a couple of months ago, that they need that constant. When you're in the midst of an emergency, you need to have that training so that people's awareness is peaked at that time, and you're able to help them with their practices. To that hand hygiene, recognizing, oh, wow, we need to wash every time. We need to recognize that we can come in contact with the virus, not only directly with the patient, but with the patient's materials around the patient. And I think I remember one case where the physiotherapist was in very close contact with the patient, not recognizing that they would be susceptible and vulnerable.
If there are no other questions and comments, again, I would certainly like to say that this is certainly an interesting topic. I know Dr. Philippe mentioned one of the risk factors being fatigue, and I think that was shown throughout the literature. So it is absolutely most important, and recommendations for all of us are to continue to wear your full PPEs. I think that was also borne out in the information that was provided to us, and proper hand hygiene as well. So certainly, Dr. Philippe, we look forward to future research from the Ministry of Health. I know that this was done in 2020, so looking forward to perhaps work that.
For the opportunity to participate and encourage the research, even in the midst of a pandemic or disaster. It is important that we do our own work. Thank you so much.
You're welcome. And so firstly, to myself as in my excitement to hear the keynote speaker and to get this session started on community health and family medicine. Again, I'm Dr. Sabrika Pinder-Butler, family medicine consultant and coordinator of the postgraduate program for the University of the West Indies School of Clinical Medicine and Research. And so at this moment, we will now hear several interesting resident papers. The first coming from our own Dr. Danielle Strawn-Boleg, a family medicine specialist, a recent DM graduate. She will be presenting her findings on her DM entitled Knowledge Regarding Metabolic Syndrome and an Adherence to the Ncep ATP3 Clinical Practice Guidelines among physicians in New Providence, the Bahamas. Let us welcome Dr. Danielle Strawn-Boleg. We will now hear her presentation.
Good evening. My name is Dr. Strawn, and I will be presenting my research entitled Knowledge Regarding Metabolic Syndrome and Adherence to the Ncep ATP3 Clinical Practice Guidelines among Physicians in New Providence, the Bahamas. I have nothing to disclose. Due to sedentary lifestyles and excessive caloric intake, the metabolic syndrome, or MET-S, is becoming an increasingly common health problem in the world as well as in the Bahamas. This syndrome groups cardiometabolic risk factors that result in elevated risk of cardiovascular disease, type 2 diabetes, and more importantly, mortality. There is currently a debate challenging the significance of diagnosing MET-S in clinical practice rather than treating individual risk factors. This multifaceted clinical phenomenon is encountered in all fronts of primary care, and although evidence-based guidelines and effective treatments exist, there is a wide therapeutic gap between guidelines and practice. This treatment gap is largely attributed to physician and patient adherence, and exploration into physician attitudes regarding adherence to any particular guideline, specifically the Ncep, for MET-S management is therefore of interest. According to the AHA, MET-S is defined as a constellation of interrelated risk factors of metabolic origin that appear to directly promote the development of atherosclerotic cardiovascular disease. Studies have shown the prevalence of MET-S continues to increase globally, regardless of the definition used. In 2012, the Bahamas STEP survey, 43% of participants were found to be obese, and 72% had extremely high risk for developing cardiovascular disease. As highlighted and previously mentioned, my study will be focusing on the Ncep ATP3. This is a visual representation of differences in criteria for MET-S, the WHO being first in 1998, and the Ncep later in 2001, and then modified again in 2004. So it has been proposed that uncertainty exists about the clinical and public health importance of MET-S. The majority of prospective studies have presented risks based on the Ncep definition. Ncep ATP3 criteria proves to be more efficient for clinical practice purposes and has been used in most studies in assessing MET-S. Therefore, it would be beneficiary to assess physicians' ability to diagnose MET-S as defined by the Ncep criteria. The aim of this study was to determine the knowledge of physicians in New Providence, Bahamas regarding MET-S and adherence to the Ncep ATP3 guidelines. The objectives: to assess health literacy of physicians in regards to MET-S, to assess physicians' experiences in screening for MET-S, the extent to which physicians perceive they engage patients in health education about the involved cardiovascular risk, and to assess adherence to the Ncep clinical practice guidelines. A cross-sectional survey design was used, including physicians in all staff levels, training in primary adult health care in both the public and private sectors. A minimal sample size of 196 physicians was calculated via Cochrane's formula, and this study had 110 participants. The instrument used was a 3-part questionnaire adapted from 2 previous studies, including a modified metabolic syndrome knowledge level scale. Of 162 physicians approached, there was a response rate of 68.3%. The mean age was 38.6. Listed in tabular form are the other demographics with those highest values highlighted. In regard to participant specialty, family medicine represented 53.5%. To account for specialties that represented only 1%, specialties were grouped based on similarity for ease of statistical analysis. MET-S health literacy. Participants reported MET-S awareness by answering the following questions. When asked if they were familiar with the term MET-S, 99% said yes, and 88% admitted to treating patients with MET-S. When asked, does metabolic syndrome influence prognosis, 98% said yes. Is MET-S considered to be a risk factor for cancer? 75% said yes, and all of physician participants agreed that MET-S is prevalent in our population. 60.9% of participants answered that they feel any physician should treat MET-S. Pertaining to participants identifying the number of criteria comprising MET-S according to Ncep, 67.9% identified 5 as the correct total number of criteria in the Ncep guidelines. Consultants perform best on this question, with 96% correctly identifying the number of criteria. Subsequently, 67% of participants correctly identified 3 out of 5 as being the correct number to make the diagnosis of MET-S, according to the Ncep. All senior regs correctly identified the correct number of criteria 3 out of 5 needed to make the MET-S diagnosis. When participants were presented with 5 consecutive clinical scenarios regarding the definition of MET-S, findings were as follows. Each clinical case outlined a patient with values consistent or not consistent with the diagnosis of MET-S. All cases except number 3 were consistent with the definition, and 44% of participants correctly disagreed that the third case did not meet MET-S criteria. The MET-S knowledge level scale. This survey consisted of 25 questions, all about MET-S knowledge. This table depicts frequency of correct answers obtained, and these percentages highlighted are the questions with least favorable performance, less than 50%. The percentages starred represent those questions that were statistically significant. 82% of participants obtained a score of 75% or higher, with the highest percentage of participants scoring 88%. The median score in the MET-SKS was 84%, with a minimum of 0 and a maximum score of 100. When grouped by level of training, consultants had the highest median score with 88%. By specialty, IM had the highest median score with 88%. Physician experience with screening. 41.3% of participants indicated they sometimes evaluate for MET-S in their patients. By level of training, consultants did so more frequently with a median frequency of often. Participants reported on whether they measured waist circumference, and all levels of training except SHOs did so occasionally, again differing by IQRs and registrars having the closest range. Participants' median frequency with which they calculated BMI differed by their specialty grouping. Both general practice and family medicine groupings calculated BMI often. The median frequency of calculated ASCVD risk also differed by specialty groupings. Only IM calculated ASCVD risk score often, with more than 40% within the specialty. Physicians' perception on health education. This part of the survey asks about screening and adherence to guidelines and health education. When asked how often participants screen adhering to the Ncep, sadly, only 27% reported sometimes. In comparison, they did so more frequently, screen for comorbidities and isolation with a median frequency of often at 44%. When asked, do you counsel your patients on lifestyle modifications? And do you engage patients in health education regarding cardiovascular risk? The median frequency was every time, with more than 50% for both questions. The median frequency with which participants recommend adjustment of risk factors upon discharge was always at 45.4%. Weight loss was the most commonly recommended risk factor for adjustment, followed by blood pressure. Family medicine and IM groupings engage in health education every time. However, differences in medians and IQRs in comparison to other specialties. And although the median frequencies are the same here, with often in regards to whether participants feel their patients are informed about CV risk post-visit, distribution of the IQRs were all statistically significant. Adherence to the Ncep guidelines. More than 50% of participants use Ncep criteria when diagnosing MET-S. Of the 52 participants in the family medicine grouping, 73% use the Ncep guidelines. Regarding participants' knowledge of parameters consistent with the Ncep guidelines and the ability to identify the 5 criteria, 56% correctly chose category C. When done by specialty, more than 60% of both FAM, Med, and IM groupings both correctly identified parameters of Ncep criteria. So in regards to MET-S literacy, over 90% of participants were familiar with the term MET-S, and over 80% admit to treating patients with MET-S. And this was found to be similar to the model study done in Israel, where over 90% of participants were familiar and treat patients with MET-S on a regular basis. Over 60% of physicians identified the correct number of criteria as well as identified the correct number to make the diagnosis of MET-S. In the MET-S-KS, 82% of physician participants obtained a score of 75% or higher. The average MET-S-KS score was 84%. This translated to a high level of MET-S knowledge for the physician population canvassed. Consultants scored the highest median score of 88%. IM specialty scored the highest with 88%, followed closely by family medicine with a median score of 84%. The median frequency with which participants reported screening adhering to the guidelines for MET-S was sometimes. Those participants that screened for comorbidities in isolation, the median frequency was often. The median frequency with which physicians engage in health education was every time. This speaks well to the Bahamian physician population as it relays they are following through with their duty to ensure patients are educated, empowered, and held accountable about their own health. Adherence to the Ncep guidelines, 53% of participants admitted to using the Ncep as diagnostic criteria, and further to that, 56% of participants were able to successfully identify the parameters of the Ncep criteria. This would suggest only adequate, not satisfactory adherence to the Ncep guidelines. These are some of my limitations. And in conclusion, there's a high level of MET-S knowledge in physicians in New Providence, Bahamas. Physician participants admit to sometimes adhering to the Ncep guidelines when screening patients for MET-S, and more so screen for comorbidities in isolation. As years in practice and level of training increases, knowledge level, frequency of screening, and engaging in health education increases to every time. Family medicine specialty was found to have the most knowledge of and most often adhere to the Ncep clinical practice guidelines for MET-S. These are my references, my acknowledgements, and thank you.
Thank you, Dr. Strawn-Boleg, for an excellent presentation. Do we have any questions or comments for Dr. Boleg? Dr. Dorsett, you can go ahead.
Okay, thank you. So thank you, Dr. Boleg, for that interesting paper that you did. I wanted to know your thoughts about perhaps us including waist circumference along with when we do our weight measurements for our patients. Do you think that might be a practical thing that we start including with our vitals?
Good evening, and thank you for your question, Dr. Dorsett. This is a good question, and I actually do think that we should make it routine when we're seeing our patients, because funny enough, in my study, physician participants recognized that there was a difference in the values for waist circumference for men and women. They recognized that there was a link to cardiovascular risk, but they all reported that they never do it in practice. And so with the Ncep guideline, what it does is it encourages you to do waist circumference in your clinical daily practice because it is one of the criteria to make the diagnosis. So I would agree that we make that an everyday practice when we are seeing our patients, because it could be a good baseline landmark, especially for them. They have a number that they can follow as well.
Thank you. Are there any other questions or comments for Dr. Strawn-Boleg? Certainly, I agree that it is a very important topic, certainly when we know that the knowledge is there and we are aware of the guidelines, and now we have to move that into our practice. And something as important as relating to metabolic syndrome and its implications for our patients' health. I think this is a Very good topic. Thank you for the work that you've done, Dr. Strawn-Boleg. And if there are no other questions or comments, we will get ready for our next resident presenter. Okay, Dr. Frankson wants to make a comment. Go ahead, Dr. Frankson.
Okay. Thank you very much for that presentation. And I was having a problem finding the chat and so forth. Anyway, the issue that I wanted to raise was, well, there are many interesting issues. The one that really I thought I found interesting as we worked on this together was you could have a whole group of people having the same medians. So watching for the median alone is not sufficient. And you quite rightly demonstrated with the box and whisker plot that it is really important not just to look at the measure of central tendency, like the mean or the median, but also to go and find the differences by looking at differences in the distributions of the interquartile range. I thought that was very important. And it also points to areas where you could actually then bring up some of the other groups if you were to do continuing medical education and things like that, because you wanted to shift their middle 50% up to the desired range. Had to make that comment, Dr. Binderbutt.
I'm sure you did, and Dr. Strawn-Boleg appreciates that comment. That is certainly intuitive with your specialty, Dr. Frankson, as our in-house statistician epidemiologist, and we appreciate your efforts as well. Thank you again, Dr. Strawn-Boleg, for your presentation.
Thank you.
So our next exciting resident paper will be on the topic exploring the associations between trauma and victims, drug and alcohol use in patients seen in the Accident and Emergency Department at the Princess Margaret Hospital, Nassau, Bahamas. Dr. Madeline Joseph, another recent emergency medicine graduate, will present her interesting findings to us at this time.
All right, as I was saying, my research topic is assessing the associations between trauma and victims' drug and alcohol use in patients seen in the Accident and Emergency Department of the Princess Margaret Hospital. I have no disclosures. The World Health Organization defines unintentional injuries as road traffic accidents and intentional injuries such as stabbings, suicide, or even war. The Bahamas has had a long-standing history of drug and alcohol transshipment, and the relationship continues. Pre-pandemic, the Princess Margaret Hospital had a bed capacity of 400 beds. The ill effects of the drug and alcohol use inundated the Accident Emergency Department. In 2013, the police crime statistics reported 255 deaths from accidents, suicides, and homicides. This is a 6.7% increase from 2012. There continues to be an upward trend in the number of ED visits. Between July 2015 to June 2016, there were 53,062 ED visits. 2.37% of those visits were secondary to intentional injuries, while 2.57% of those injuries were secondary to road traffic accidents. Economist Intelligence Unit found that the Bahamas rank #1 in the Latin American countries and the Caribbean for fatalities in road traffic accidents, recording 26 deaths per 100,000. The Royal Bahamas Police Force crime statistics noted that there were 144 murders in 2015. And this, ladies and gentlemen, made 2015 the 5th consecutive year where the murder rate was greater than 94. alcohol and tobacco are first and third most important risk factors for ill health and premature death in low-income countries. Study by Bus et al. Of 233 urban trauma patients found that 50% of the study participants admittedly used alcohol or drugs before sustaining injury. Muchen et al. Assessed 9 studies between 6 different countries and found that marijuana use increased crash risk with a prevalence of 2 to as high as 56%. The aim of the study was to explore the possible associations between trauma patients and his or her drug and alcohol use who were seen in the accident emergency department at the Princess Margaret Hospital. The objectives were to determine the medical socio-demographic profile of these trauma patients, to determine the prevalence use of alcohol and other illicit substances, and to assess the severity of trauma in relation to the type of substances used among trauma victims, and also to quantify the level of injury using the injury severity score. This was a cross-sectional study taken in October 2017 to June 2018 in the emergency department of the Princess Margaret Hospital. Patients in this study were between the ages of 18 to 80 who sustained traumatic injuries, whose Glasgow Coma scale was greater than 13, and those who consented to taking part in the study. Patients were excluded from the study if their Glasgow Coma scale was less than 13, or they were unstable, or they sustained traumatic injuries from sexual assault, or they simply refused to take part in the study. The minimum sample size was calculated at 288, and a sample size of 318 was used. Ethical approval was attained, and authorization was given by the hospital administrator and the chief of service of the accident emergency department, Dr. Krista Wells. Then an Audit C questionnaire was used, and the latest version of the IBM SPSS statistical analysis application software was applied. For this study, descriptive and inferential statistics was generated. This included appropriate measures of central tendencies. We found that the median age for the study participants was about 35 years. 60% of the study participants were male, 83% of the study participants were single, and 62% of the study participants completed high school, and 10% of the higher degrees in the study participants was among the female patients. 60% of the study participants injured were fully employed, and 94% of the participants sustained injury in New Providence, and 74% of the study participants were discharged home. Alcohol use in the last 6 hours before being injured was reported in a third of the study participants, and 49% stated that they had never consumed alcohol, while more than 50% admitted to having from 1 to more than 10 drinks per day. In looking at the use of marijuana in the last 6 hours, 30% of the study participants admitted use of marijuana before being injured. When comparing gender and drug use, it was found that 131 or 67% of the study participants used some form of drug or alcohol before being injured, while the majority of the female patients denied drug use. With respect to the type of trauma, we found that 35 of the study participants sustained violence, used marijuana within 6 hours before being injured. Interestingly enough, The victims of intimate partner violence also admitted to marijuana use before being injured. With respect to the type of trauma, 181 out of 318 of the study participants sustained blunt force trauma. With respect to the frequency distribution by level of injury, we found that the minor injuries were head injuries, with the lower limb injuries coming in a close second. With respect to the severity of injury, it was found that the lower limbs sustained severe or critical injury more than any other anatomic part. So the age of the study participants range from 25 to 45, with the median age being about 35. This is comparable to the study performed by Fountain et al. In 2008 in the accident emergency at the Princess Margaret Hospital, where he found that the mean age of the study participants was 38 years. 60% of the study participants were male, and the majority of the study participants at least completed high school, with tertiary degrees being found in the female participants. The majority of the study participants were employed, and 90% did not have any chronic medical illnesses. Fountain et al. Found in 2008 that 8% of the road traffic accidents and 11% of the street violence occurred in the trauma patients presenting to accident emergency. In 2017 to 2018, the number of road traffic accidents tripled and the street violence doubled. With respect to drug use, 30% of the study participants admitted to some drug use within 6 hours of sustaining trauma. This is comparable to previous studies by Vital et al., where he found that 35 to 40% of the participants admitted to cocaine or marijuana use before being injured. This percentage also compares to what Mr. Fountain found in 2008, where at least 30% of the study participants were involved in some illicit alcohol or drug use. Injury severity was 16% of the total number of study participants where the head was injured. Limitations to this study included that there were patients who were not sampled because of the sensitivity of the questions and their suspicion of prosecution. Some of the patients opted not to take part in the study, even when they were reassured. The true number of trauma patients has been skewed simply because the patients with minor injury who still need to present to Princess Margaret Hospital opt to not present to hospital or to go to a different hospital. Some of the study participants were reluctant to be truthful to disclose the type or even the quantity of drug use for fear of prosecution. And also, no objective tests were used to corroborate the persons who denied use of alcohol, marijuana, or other drugs. Street violence continues to dominate as one of the major causes of morbidity and mortality in the Bahamas. Binge drinking appears to be a leading cause of traumatic injuries from road traffic accidents. And intimate partner violence also accounts for a substantial number of patients. In conclusion, tobacco smoking is also negligible as a causal factor for trauma, while marijuana smoking is significant in the male victims of trauma. As more research is conducted, the causal factors will become more evident. My recommendations are that increased police surveillance, the formulation of a trauma registry is needed, testing for illicit substances is needed, Education of the masses is also needed. Implementation of policies and laws are needed, and addressing the social issues within the community. I would like to thank Dr. Krista Wells, Dr. Wesley Francis, and others for all of their help in this academic effort. My references. Thank you.
Thank you, Dr. Joseph, for a wonderful presentation.
So how do you think this presenting that marijuana, because that's what I understand, marijuana impacts negatively on injury and violence? How would you translate that to the community when the community thinks that marijuana makes you chill, cool, less violent?
Thank
Or
you for that.
is it an amount of marijuana they smoke? Because you said you didn't do any blood testing to see the level. Mm-hmm.
Thank you for that fabulous question, Dr. Dorsett. Well, usually the smokers of marijuana only think of, okay, I'm getting high. But when you relate it to the amount of money spent, when it affects their money, then the response is different. So if I talk about you need to quit because your health is at stake, it's a habit. Modifying that habit for a healthier lifestyle may be difficult. But if I say, if you smoke 5 joints a day and each joint is $5, let's multiply that by a week. Let's multiply that by 365. So for the majority of the patients I meet, when I relate it to their money, they say, boy, I think I could cut back, you know. But in the emergency room, when they are trauma patients, if we think they are altered, when they are less inebriated, and we try to have the conversation, if the tone is accusatory, they don't listen. And so to help modify behavior, we probably need to find different ways instead of telling them stop smoking. But if we tell them that you're spending too much money, we could use this money on something else that's more beneficial to you, then maybe they'll listen. But definitely modification of such habits needs to take place because it's affecting our numbers in hospital.
Thank you.
Are there any other questions or comments for Dr. Joseph? Dr. Dorsett?
Hi, thank you, Dr. Joseph. That was very interesting. I wanted to know your thoughts about with the intimate partner violence. You said that the main substance that was admitted to being used prior to being injured was marijuana. So I just wanted to know your thoughts about, I guess, the association of substance use with being a victim.
Thank you for the question, Dr. Dorsett. Dr. Dorsett, regardless of what the patient does, we can't blame the victim, really. We can't blame the victim. And I guess in further studies of this kind, maybe I can assess the drug use of the perpetrator. Maybe that'll be more helpful. Because even though I measured some patients who sustained violence from their partners, it's not to say that they were so altered, they were part of the reason why somebody was violent against them. For some of the patients assessed, it seemed as though I was sharing a joint with my boyfriend, and I inhaled too much. He thought I took too much of it. I hope I answered your question.
Yes, thank you.
All right. Thank you again, Dr. Joseph, for a wonderful and thought-provoking deal of great research. Certainly, I think that it would be important for us to get this information out as widely as possible, because I think too, some persons may not be aware of what these effects might mean to them, although we do know that we've been seeing an increase, as you mentioned, a significant increase in violence and accidents. So certainly something for us to disseminate as widely as possible to try to curb this problem. Thank you again for great research, and to your team as well. Excellent job.
Thank you.
Right now, we are going to have an announcement from the Medical Association of the Bahamas.
Our lives have been turned upside down since the COVID. Our lives have been turned upside down since the COVID-19 virus entered the Bahamas. Our lives have been turned upside down since the COVID-19 virus entered the Bahamas. We have been encouraged to increase our hand washing, to remain. Our lives have been turned upside down since the COVID-19 virus entered the Bahamas. We have been encouraged to increase our hand washing, to remain socially distant, and to wear masks. During this pandemic, many have lost their jobs, and some have sadly even lost their lives. We know that this time continues to be a trying one, and we thank you for following the protocols and remaining resilient. I am Dr. Cindy Dorsett, President of the Medical Association of the Bahamas. My members and I need your help once again as we navigate this new norm. What we do as individuals will impact everyone's health. COVID-19 vaccines are now available, and it's important for you to acquire information from reliable sources. We want you to know the facts. These vaccines are safe and effective. People you know and trust are getting vaccinated. Your leaders, your ministers, your healthcare workers, and even your family members. I rolled up my sleeve and got the shot because the evidence shows it works.
I got my shot so I can go back and doing the things that I enjoy in life.
I got my shot to play my part and to continue serving safely in our community.
I chose to vaccinate to protect myself, my family, and my patients. I pray that you get vaccinated too.
I got my shot because I know that it went through the same safety checks as any other vaccine.
I got the vaccine because I needed to protect myself and my family.
We all want to reunite and travel and get back to school and work safely. It's going to take all of us.
We are counting on you.
This is our best shot.
This message has been brought to you by the Medical Association of the Bahamas.
We will now resume our residence papers. And we have another wonderful body of research that we will hear presented this evening. Dr. Sunita Belgrave, a recent family medicine graduate, will be presenting her research work to us on barriers to HIV testing and linkage to care for persons living with HIV and AIDS in New Providence, Bahamas, the patient's perspective.
Good evening. I am Dr. Belgrave, and I'm going to present to you the barriers to HIV testing and linkage to care for persons living with HIV and AIDS here in your province. Nothing to disclose. We are living in the era of the novel coronavirus. And one thing we know is that whenever there's a new virus on the block, fear follows. Maybe this same fear has driven the media to mention HIV over 70 million times. But one recurring question is the HIV cure close? HIV eradication would be the ideal way to address the complications of HIV. The World Health Organization notes it to be a permanent reduction to zero. HIV eradication could either be a sterilizing cure or a functional cure. A sterilizing cure is where you have complete elimination of the HIV DNA. A functional cure is where you have modification of the receptors. This sends the HIV virus into remission and replication ceases. Just 2 years ago, the former Minister of Health, Dr. Dwayne Sands, noted the Bahamas hopes to eradicate HIV by 2030. He was referencing the fast track, ending the AIDS epidemic by 2030, where 95% of our patients will know their status, 95% of our patients will receive treatment, and 95% will have viral suppression, all at a cost of zero discrimination. Worldwide, there are 37 million persons with HIV. Regionally, 310,000 persons with HIV. And locally, 5,200 cases. The reality is we are faced with a high disease burden and a low cure rate. As we look to the literature, we find a more practical approach to addressing HIV, the HIV care continuum, where 100% represents the amount of persons with HIV infection. 87% represents the amount of persons actually knowing their status. And 75% represents the amount of persons linked to care, defined by the CDC of having a documented viral load or a CD4 test within 30 days of diagnosis. There's a subsequent drop in the percentage of persons who are actually retained in care and having undetectable viral loads. So what we want to do is to zoom in on those persons who are HIV diagnosed and linked to care. Maybe if we understand their challenges when it comes to getting tested and seeking care, we can increase the retention of persons in healthcare. And by understanding their plea, we can get more persons tested and treated. So we joined the UNAIDS Global Action Plan. We want to understand their social demographic profile, their barriers, particularly as it relates to HIV testing and linkage to care. So we targeted adults with a confirmed HIV diagnosis. We then sought out those who were enrolled at the HIV health clinics, and we sampled at 3 catchment sites: the PMH Infectious Disease Clinic, the HIV Center at Victoria Gordon's, and the Family Medicine Clinic. From there, we were able to study eligible partners who were willing to fill out our questionnaire. Participants were briefed, consent was obtained, and a questionnaire was distributed, similar to this one. The minimum number of participants needed was 363. We were able to get 381. Descriptive and inferential statistics were done on IBM SPSS. These are the results. Participants had a median age of 47 years. There were slightly higher male distribution at 56%. Participants were mainly Black, Bahamian, and having up to a secondary level education. Participants were mostly single, employed, and receiving a yearly income of less than $10,000. They tended not to have health insurance and was of a Christian Protestant faith. Most persons living with HIV self-identified as heterosexual, with 60% of persons revealing only having HIV. Extrapolating from the information, we found that 73% of persons were linked to care. After their diagnosis of HIV, we saw an increase in polypharmacy of about 22%. But what exactly were these barriers to HIV testing and linkage to care? Well, at a patient level, persons were unaware of HIV home testing kits. They had to disclose their status to their partner, and persons associated HIV with only bad outcomes. They had inadequate prior knowledge to HIV and AIDS and no risk perception to the virus. They knew they were going to experience friend or peer discrimination, and they were fearful of even knowing their HIV status. Many persons perceived that people living with HIV looked sick, and they were fearful of death or even losing their job. At a healthcare level, they noted the doctor failed to offer them an HIV test. Some persons believed the nurse or even their doctor would disclose their results. At an institutional level, they had inadequate knowledge of the HIV testing clinics or centers in the community, and they had inadequate knowledge of services and believed that the hospital or clinic would disclose their status. Now, we hear a lot about knowledge and education, but of note, persons with an inadequate prior knowledge to HIV had a median level of education as secondary. After they were diagnosed with HIV, they continued to face barriers. At a patient level, they experienced psychological stress. They believed their culture was less accepting to them, and they had feelings of self-embarrassment or shame. They feared their families' or friends' perception of them, and they feared status disclosure to their loved ones. Many persons denied having symptoms and questioned the accuracy of the results. As a result, they denied their diagnosis of HIV, and many feared disclosure to their own partner. At a healthcare level, taking more pills was just difficult, and many persons did not understand their doctor's language or explanation of HIV. At an institutional level, they preferred medications to omit their names, and some fear the treatment program may become unavailable. But what does all this mean? Well, firstly, we found that our population mirrored the data, accepting that persons here were mostly employed. Interestingly enough, we also saw low health literacy, whether it was their knowledge, their risk perception, or just being unaware about clinics and services. The literature also highlighted this, particularly in de Blonde et al., a systemic review of over 24 studies, which showed that low risk perception was a major barrier. Another point I want to highlight is that healthcare specific barriers were their smallest hurdle. In the literature, we see how healthcare and institutional factors are also less of a concern. As it relates to linkage to care, we heard about psychological stress, the culture less accepting and fear of status disclosure. We heard about self-embarrassment and fear of perception and denial. But who could blame them when disclosure was linked to higher levels of discrimination and physical harm? At a healthcare and institutional level, they were clear. They had difficulty taking more pills and they did not want medications with their names on it. This was not a major concern in the literature, however. But overall, we see at a social-ecological level that persons were affected at an individual, interpersonal, organizational, and a community level. So what is left for us is to put policies in place. So these are just some of our recommendations. HIV campaigns should focus on target groups, particularly males, those in secondary school and religious organizations. We need to strengthen the HIV knowledge building. A periodic review of medications is warranted to address polypharmacy. And we need to offer an opt-out system for HIV testing and an opt-in system for names on medications. Our study did have limitations, particularly reading difficulty and in the literature an adult with some person greater than 15 years. In conclusion, the fight is not over. We need to focus on health literacy and address barriers at a social-ecological level. These are my references, and I thank you for listening.
Dr. Pinderbutt,
Go ahead, Dr. Frank.
could you, anecdotally, if you want, say how all of this problem has been compounded by the pandemic that we're going through?
I'm sorry, I did not hear the comment. Given my internet, it's a bit slow.
Can you hear me now?
I can, but I'm getting an echo.
I hear the echo as well.
Okay.
Let me go ahead anyway. Could you comment, even anecdotally, as to how you think the pandemic has compounded this problem?
Okay, thank you so much for your question. If I heard correctly, you want to know how the pandemic has compounded this problem. So the good thing was that we were able to finish the study just before the pandemic started. So as a result, our clinics were still at capacity, so we were able to capture the patients that we want or the demographics. Now, if this study was done in the pandemic, it would have been a little more difficult because first of all, a lot of persons were scared to even come to clinic. Some clinics had to go on less numbers and also had to close clinics at times. And so you would not have been able to have that interaction. Another thing is for patients who had reading difficulties, we were able to have some person to read the questions to them in some instances, and that may not have been available during the pandemic. Now, when it came to the results, I truly think when it came to demographic profile of we seeing more persons who were employed post the pandemic or even during the pandemic, I do believe that that percentage would have dropped to more persons being unemployed. The pandemic itself could also factor in a barrier for persons even wanting to become tested. Persons were just scared to come forward to see any type of personnel. So we can see how the pandemic had affected us getting data and also persons coming into the clinic and adjust our results.
Thank you.
Any other questions or comments for Dr. Belgrave? Certainly, we continue to encourage the residents with this work because we know that a great deal of effort goes into obtaining your result. And so we again commend you for your work and the efforts of your team. Dr. Philippe?
Yeah, well, thank you so much, Dr. Belgrave, for this presentation. I think it takes us back many years when in the Ministry of Health, I think it was 2009, we considered the decentralization of HIV services. As you did this survey, did you get a feeling that we should decentralize or continue to keep the service centralized in terms of the provision of services? It's unfortunate to still see that patients are concerned about the confidentiality of their information. What is your recommendation for the system as a whole?
Thank you for your question. And that's actually a really good point that you brought up about decentralization. So the reality is it has its pros and it has its cons. Now, some of the patients noted to me that with the particular clinic being moved out of Victoria Gardens and into the PMH infectious disease clinic, there were still persons who knew that that was the time the clinic was held. And they explained to me that persons who had no regards to being in that clinic will literally come and sit in the clinic. Say, for example, it's a Wednesday morning, they will literally just come and sit there to kind of find out who is coming through the clinic. So as a result, they started to bring, like, one lady told me she brought her father with her every time, so that when these onlookers came, it would appear as if she was bringing some person with her, that she was bringing a patient when she herself was the patient. So even though decentralization does sound great, it does have its own challenges and its own factors, but hopefully we can get to a time where it's a desensitized. At the end of the day, it's another condition that's being treated. And if persons feel stigmatized, they're not going to come and get treated. And we're going to continue in this continuum where we have persons not being retained in care, the viral loads are not being suppressed, and so we're going to be having the transmission being greater in the country.
So you think we should move the clinic out of PMH, having heard this story for many years now, that people come and sit? Do you think listening to the patients, doing this study, and identifying their concerns, should we not respond?
I still think it's a hard question to answer, because if you move it to say, let's say, Anstown, persons can come from PMH, they could go and sit in Anstown. So it has to be more than just a move of location. I think it has to be a movement of mindset. And that's why we need to have campaigns that deal with desensitization, and also however we can preserve the privacy of our patients, we should. For example, in the United States, there's a particular clinic that they have. And when the person comes in, there's no names, you just pick a number, you just go in and you come out. And you could be coming for hypertension, you could be coming for diabetes, you could be coming for HIV. And maybe something like that would work better, where you just have multiple clinics at the same time with no names, but maybe like a computerized number system, as opposed to just a movement from one location to another, because people are very smart and we might think that works, and then they will still find ways to figure out, oh, this is the HIV clinic, let me sit here now. So I think it is going to be a little more than just a movement from one place to the next.
Thank you so much.
Okay, thank you. Dr. Dorsett, if it's a quick comment or question, we can take it, because we're almost out of time with this.
Yes, quick question. So thank you, Dr. Belgrave, for that. I wanted to, so you highlighted one of your recommendations that we improve the education for persons who have been diagnosed with HIV, as well as, I guess, the public in general, to try reduce the risk of HIV. I know we've had television, information campaigns. I've seen police officers on the street stopping, giving out PrEP and what have you. I just wanted to find out from you, what do you think we could do maybe moving forward, starting tomorrow when we see our patients, to help begin address that concern?
Thank you so much. That's such an excellent question. I was actually in conversation with someone about this recently. And basically, we just have to hold tight and just keep doing what we're doing and improve it every time. Say, for example, right now, social media seems to be a big platform for getting messages out there. We have to be willing to use it, whether it is TikTok, whether it's Instagram, whether it is Facebook. That is one avenue. We need to utilize celebrities who can get the word out. We need to utilize patients who feel comfortable, whether it's turning their back or getting their stories out. When the HIV month comes up, we need to utilize that month to a great extent and just continue telling people and getting the education out. And as you know, as a physician, you could talk to a patient today and a month later, another physician sees them and say, oh no, doc, I've never heard that before. So we just have to be consistent. We just have to get that information out multiple times. And even though it may seem like we're doing a lot, we just need to keep pushing and telling our patients about it, because we need them to help us in this fight. It's not as simple as let's give medications. We need them also for great practices and to get that information out. So thank you for your question.
Thank you again, Dr. Belgrave, for an excellent presentation, and we wish you all the best in the future. Our final resident paper is also another interesting topic: community members' perceptions of infertility in Nassau, Bahamas, and Kingston, Jamaica. Dr. Janelle Osadabe-Brown, recent obstetrics and gynecology resident and graduate, will present this excellent work to us now.
Good day. My name is Dr. Janelle Osadabe-Brown, and my research being presented today is entitled Community Members' Public Health Perceptions of Infertility in Nassau, Bahamas, and Kingston, Jamaica. I have no disclosures, but this presentation was also a poster presentation at this year's Royal College of Obstetricians and Gynecologists Conference. The World Health Organization defines infertility as a disease of the reproductive system defined by the failure to achieve a clinical pregnancy after 12 months or more of regular, unprotected sexual intercourse. Despite this definition, many believe that efforts to achieve a successful pregnancy is a matter of a socially constructed need instead of a medical condition. Additionally, many health insurers do not think of wanting a child as a medical necessity. Infertility has a strong social undertone for how those affected are viewed by the community, family, friends, and by themselves. We cannot deny the strong hold that old wives' tales have over the psyche and in turn lead us to do certain things and act a certain way. Couples that experience infertility can attest to a level of anxiety and distress and may equate it with failure on a personal, interpersonal, emotional, and social level. Unfortunately, women usually experience the burden of condemnation as well as sympathy. The infertile woman, according to Fido and Mascarenos, exhibits significantly higher psychopathology in the form of tension, hostility, anxiety, depression, self-blame, suicidal ideation, and discrimination. In the United Kingdom, 1 out of every 7 couples are affected by infertility, whereas the prevalence is around 10 to 15% in the United States. Despite this, the number of couples seeking medical help for infertility is usually lower than the number experiencing it. This leads us to the question of prevalence in the Bahamas and Jamaica. A follow-up question would be, why is assisted reproductive technology still so expensive? The laws of supply and demand seem to be lost on this concept, seeing that studies all over the world report that infertility and persons seeking out assisted reproduction services have increased over the years. Hence, the concern about access to assisted reproduction if needed. The objectives for this study were to ascertain the prevalence of infertility in the Bahamian and Jamaican community, to evaluate persons' knowledge of the topic, to assess the need for assistance in assisted reproductive efforts, and the design was a population-based cross-sectional study. A self-reported survey questionnaire was administered based on literature reviews, and no identifying markers were necessary. Written consent were obtained from all adults willing to take part, 18 years and older, and from teenagers 16 to 18 with a parent or guardian consent, being that the age of sexual consent is 16 years old in both countries. The ability to read, understand, and write in standard English was also a requirement. Completed questionnaires were kept in sealed envelopes in a locked filing cabinet. Data entry was on a password-protected computer of the biostatistician, and the calculated sample size was a minimum of 323 participants for each site. This shows the breakdown of the number of participants at each site. In the Bahamas, the sample size was shy of not being attained, but in Jamaica, the sample size was exceeded. A total of 686 persons participated overall. This graph shows the breakdown by sex at each site. The Bahamas is represented in blue and Jamaica in red. At each site, there is an overwhelming female response, with Jamaica having a slightly better male response compared to the Bahamas. Unfortunately, the request response rate was not recorded, but during administration of their questionnaires, many of the men initially did not mind partaking, but once the topic was revealed, they tended to politely decline. Quite a few of them even pointed investigators in the direction of women, indicating that, quote-unquote, they would be better persons to ask. The majority of participants from the Bahamas were greater than 44 years old, and the majority of participants from Jamaica was between the ages of 27 and 32 years old. In both sites, the majority identified themselves as being single, and the majority in the Bahamas had an education level up to a college level, while for Jamaica it was up to a high school level. This graph shows how our participants responded to the question on their thoughts about infertility being a disease. The Bahamas is represented in blue and Jamaica red. The majority of Bahamians strongly disagree to the concept of infertility being a disease, while the majority of Jamaican participants slightly agreed with the concept. Here, participants were asked about the time frame needed to make a diagnosis of infertility. Most participants from the Bahamas chose the time frame of not able to conceive at all, as well as most participants from the Jamaica site. Here, a whopping 78.3% of participants from the Bahamas personally knew someone having difficulty conceiving. In Jamaica, 28.8% of the participants knew of someone with this issue. This graph shows 15.4% of persons from the Bahamas side admitting to personally having difficulty conceiving. This amount drops too, but is not far off from the participants in Jamaica, with 14.4%. of them admitting to having difficulty. These values were also identified to be the prevalence for each country and were in keeping with values for the USA and UK. This was interesting because 15% of 300,000 is quite a different kettle of fish to 15% of 2 million or even 300 million. This graph shows who participants think is blamed for infertility. In the Bahamas, shown in blue, most participants indicate that women tend to be blamed, while in Jamaica, most indicate that neither the man nor woman is blamed. This table represents the percentage of participants in each site that answered these particular questions in the affirmative. Across the board, for both places, the majority of participants thought that infertility can arise despite previous pregnancy success, that adoption was a viable option for persons affected by infertility, that infertility should be medically treated, and most of them in each place had heard of IVF, in vitro fertilization. The red arrow highlights the percentage of Bahamian participants that thought that infertility should be treated medically, which is interesting because over 50% of them strongly disagreed to the concept of infertility being a disease. The yellow arrows highlight the percentage of Jamaican participants who thought that infertility should be grounds for divorce. 75.8% agree to this for female infertility, and 75.6% agree to this for male infertility. More participants in the Bahamas thought that the woman should be investigated first if a couple experiences infertility, while in the Jamaica site, more participants thought that the man should be investigated first. This table shows how participants responded to what they thought played a factor in causing infertility. Responses are in the affirmative. Although more Bahamian participants tended to agree that physiological issues and infective processes can cause infertility compared to Jamaican participants, they also tended to think that supernatural causes played a factor as well, as indicated by the first yellow arrow. Psychological stress seems to be more of a concern in the Bahamian community compared to the Jamaican community, as shown by the second yellow arrow. Similarly, the same goes for the concern of obesity between the two communities, as shown by the third yellow arrow. It would have been interesting to delve more into this with the Bahamian community, given the stereotypical measurements many in our country tend to have, compared with this concern that obesity plays a factor in infertility by almost 40% of the participants. Participants were informed that IVF is not covered by insurance in the Bahamas, nor is it in Jamaica. They were then asked if they thought that medical or insurance coverage should be provided for IVF services. As indicated by the red arrows, the majority of persons from each site thought that it should be, 84.8% and 71.6% respectively for the Bahamas and Jamaica sites. From the number of participants that thought coverage should be provided, the majority, 74.4% from Jamaica, thought that coverage should be unlimited. In the Bahamas, the majority, 65.2%, thought that coverage should be limited. From those that thought that coverage should be limited, they were asked to choose between various options for coverage. Options included limited to one successful pregnancy producing a child regardless of number of treatments, being limited to one treatment regardless of the outcome, being limited to 3 treatments regardless of outcome, being limited to 5 treatments regardless of outcome, and finally, being limited to a specific monetary amount. The majority of Bahamas site participants, 35.2%, chose a plan limited to a specific monetary amount. The majority of Jamaican site participants, also 35.2%, chose a plan limited to 3 treatments regardless of outcome, that is, 3 rounds of IVF. Society still has many misconceptions about infertility, but education is key and can be used to remedy this issue. The Bahamas and Jamaica are similar, yet still very different, especially when it comes to their concerns and thoughts about infertility. In some aspects, despite the majority age grouping being younger with a lower level of education, the Jamaican participants tended to be more forward-thinking, but still had work to do with their base knowledge on what can cause infertility. It would have been interesting to attempt to delve more into why they generally thought that infertility should be grounds for divorce for either partner. For the Bahamas participants, despite the majority higher level of education, it could be possible that the fact that they were older played a part in some of their responses. Their base knowledge about the causes of infertility were better than the Jamaican counterparts, but there still seems to be a lingering hold onto the supernatural aspect. Infertility, IVF, and its costs are on the rise around the world. This concern was not lost on the participants. The more pressing question would be if we are prepared for the impact this trend may have on us socially, medically, and economically. Limitations of this study included the ability to obtain sample size, which was just shy for the Bahamas site, but over target for the Jamaica site. Also, for the fact that the response rate was not recorded. Limitations on where participants could be approached in an attempt to get the best sample size representative of the community, that is, on public versus private property. The inability to delve more into the reasons behind some of the answers given by participants. Special thanks goes to Dr. Virunda advising me every step of the way, Dr. Frankson for guiding me through the numbers, Drs. DeCosta and Carroll for helping me through it all while in Jamaica, the Ethics Committee both in the Bahamas and in Jamaica for approving the study, last but not least, the participants for without them, there would be no study. These are my references. Thank you.
For an excellent presentation. Are there any questions or comments for her at this time?
Dr. Asadabe, Dr. Frankson here. Could you just offer a guess at some of the cultural differences that you think might be playing out here?
Well, culturally, I think culturally, like I said in the presentation, the age groupings might have something to do with it. Education-wise as well, but clearly education and age tended to be battling a little bit in the Bahamian population. Despite knowing what they do know, there's still social, like you said, cultural aspects that still have them believing in certain things despite them knowing factual information. I'm thinking the younger generation, so to speak, in the Jamaican population that was sampled tended to be more, I don't want to say like more open-minded, more aware. What they lacked in factual information, they kind of gave in with critical thinking skills. So they critically thought about the social aspects about it, community aspects about it, and then they approach it from their personal perspectives. So I think culturally that those were the factors that more so played for each population culturally per se.
Thank you. And you're a little human.
Thank you.
Do we have a last question or comment for Dr. Sadabe?
I do have a question.
Sure.
Dr. Osadabe, that was a very interesting and an awesome presentation. In the introduction of your presentation, you did comment about the life of the female who has to live with the concern of infertility. But when you commented about the perception within the community in Jamaica that they don't necessarily see the cause of infertility being the female, but that sometimes they consider that the source of the infertility might be the male. Does the male within the Jamaican population carry that burden of being the source of the infertility psychologically?
I think with the male carrying the burden, from what I've discussed with Dr. DeCosta and Dr. Carroll, they work in the fertility unit over there in Jamaica, and they helped me tremendously. We've actually discussed the changing trends over time that they've seen in the fertility unit. So Dr. Carroll had said that when they first started up, it was mainly women with women issues, and they had legit quote unquote women's issues with being infertile, and usually the men would never have an issue. Slowly over time, they're actually seeing more and more men being the quote unquote issue in the relationship, and they're noticing azoospermia, problems with their count. And these tend to be, and Dr. Cal said, it's not necessarily with the older men, it's more so with the younger men. And she has actually, I don't know how far she's gotten, but they actually wanted to do research on that. But they are seeing a trend now, which is also being seen all over the world based on my literature review, that more and more men, I don't know if it's the stigma that's being taken away from it, but more and more around the world, they're reporting more and more men coming forward with fertility issues, being investigated. Now, whether they were always there and just never came forward is debatable, but they're coming forward now, and they tend to be young men, supposedly with no medical illnesses. Now, why this is happening, what is their causes, we don't know. It's still being researched actively today. But there is a changing trend, which is probably why, not sure if the common public is aware of it, but I feel in terms of the common person's knowledge about it, they are aware that it does take two. It's not necessarily always the woman's fault. You have two people in a relationship. And I think that concept is being able to hit home more with couples presenting with infertility problems. It's not just being seen, especially with the younger generation. They're not necessarily looking at it as a woman's problem, stereotypically seen as a woman's problem with the older generation. With the younger generation, they're approaching it couple-wise. Is it me? Is it you? Let's go. So I hope that answers your question.
Thank you very much, Dr. Sadabé. And thank you to all of the resident papers and all that presented their papers that were done. Excellent job to all of you, and we thank you. We're now going to have our final speakers present to us for this evening. Our keynote speakers are speaking on the topic, Scrambling for Safety in the Eye of Dorian, Mental Health Consequences of Exposure to a Climate-Driven Hurricane. We will have Dr. Nadia Holder Hamilton, a senior house officer in the Department of Public Health, as well as Dr. William Hamilton, senior house officer, Department of Public Health and Climate Change and Health Leaders Fellow, who will be speaking to us this evening on this most interesting topic. Let us welcome them.
Thank you very much, Dr. Pinda Butler. It is our pleasure this evening to talk to you about scrambling for safety in the eye of Dorian, mental health consequences of exposure to a climate-driven hurricane. My name is Dr. William Hamilton, a physician within the Department of Public Health, and I also serve as the EU CARIFORM Climate Change and Health. Next slide. We have no financial disclosures or conflicts of interest with the presented material in this presentation. This paper, however, was presented at the Health Affairs Journal webinar in December 2020 under the topic, Health Effects of Climate Change. We have a remarkable list of authors on this paper. 5 of them are physicians here in the Bahamas. Dr. Dwayne Sands, a consultant in the Department of Surgery at the Princess Margaret Hospital, Dr. Sandeep Gaud and Dr. Kristen Nottage, who are both registrars in the Department of Surgery at the Princess Margaret Hospital, Dr. Nadia Holder, and myself. The remaining authors brought a wealth of knowledge and expertise to this paper, starting with Dr. James Schultz, who is the first author, as well as our corresponding author for the journal. He is an associate professor and director of the Center for Disaster and Extreme Events Preparedness in the Department of Public Health Sciences at the University of Miami School of Medicine. Dr. Zelda Espinel is a psychiatrist and psycho-oncologist in the Department of Psychiatry and Behavioral Sciences at the University of Miami School of Medicine. Dr. Stephanie Friedman is a child psychiatrist out of Mount Sinai Medical Center. Mr. Craig Fugate is the former FEMA administrator during President Obama's tenure. Dr. James Cosin is an atmospheric scientist at the National Oceanic Atmospheric Administration's National Center at the University of Wisconsin. And last but not least, Dr. Sandra Galea, our senior author, whose research we reference quite heavily in this paper, who serves as the Dean of the Boston University School of Public Health. September 1st, 2019, Hurricane Dorian is approaching the Apagos. You can see the saw blade dark blue eye wall winds spinning at 185 miles per hour. In the center of the eye, you can see directly down to the Atlantic Ocean. In just a moment, it is making landfall with the strongest wind speeds in the history of the Atlantic storms. I stopped it right here so you can actually see the very moment where the storm is over Marsh Harbor. And this is the experience we will speak about, where persons would have just gone through the strongest winds and had several hours to scramble for safety inside the eye of the storm. Next slide. So I would like to take this time to highlight several points. When a population is affected by disaster hazards, such as hurricane winds and storms surges, many residents affected by the disaster perceive their extreme risk for harm, yet only a subset sustain injury. Studies have shown that in a disaster, the size of the psychological footprint greatly exceeds the size of the medical footprint. And this was indeed evident with the passage of Hurricane Dorian. Secondly, there's a spectrum of severity associated with psychological consequences. Virtually everyone who was exposed to Hurricane Dorian experienced fear and distress, which is understandable. However, there's only a small subset of persons who progressed to psychiatric disorders, including post-traumatic stress disorder, which is sometimes described as a disorder of event exposure. But what made the difference was the degree and intensity of exposure. As I mentioned in Marsh Harbor, the entire community was impacted by the full force of the strongest winds, followed by several hours of decreased intensity inside the eye, which was followed by the rear wall of the storm, which hit with equal intensity as that of the front wall. The third point is that psychological consequences extend far beyond the time that the hazard is operating. While there was about a 2.5-day period where Dorian was spinning at hurricane force winds across the northwestern Bahamas, more than 24 months later, survivors are still coping with post-impact adversities, including resource losses, grief from death of a loved one, and many other profound life changes. So climate change drivers such as warm temperatures, both on land and sea level rise, change in precipitation patterns make the Bahamas most vulnerable to extreme weather events. And as we can see since 2015, extreme weather events have been no stranger to the Bahamas. It is important to note that our greenhouse gas emissions is negligible. However, the impact of climate change is profound. Here in 2015, we experienced Hurricane Joaquin, which is a Category 4 storm. And the destruction that Hurricane Joaquin left for the Bahamas totaled roughly $120 million. When we look at Hurricane Matthew, which happened in 2016, it happened right on the tail of Joaquin. And so many persons still were in recovery mode from Joaquin. And it was estimated that the cost to the Bahamas was $600 million. Hurricane Irma, a Category 5 storm in 2017, made history in the sense that this storm was the first time ever that a mandatory evacuation order was put in place. It's said that approximately 5,000 persons were transported to the capital. In 2019, Hurricane Dorian wreaked sheer devastation in Abaco and Grand Bahama, with at least 70 people dying. And it is estimated that the total cost of the Bahamas is in the ballpark of $3.4 billion. So the profile of hurricanes are changing, as was seen with Hurricane Dorian. And the three, we call it the trifecta that I want to highlight, is that hurricanes are becoming stronger. As we can see, Hurricane Dorian's maximum sustained winds were 185 miles per hour, with wind gusts at certain times of over 200 miles per hour. They are also slower. So Hurricane Dorian's forward-moving speed when it reached Grand Bahama actually came to a complete halt. And Hurricane Dorian was also a very wet storm with 2-story storm surges seen in the Abacos. The question one may ask is, how does climate change exacerbate hurricane hazards? And one common factor is the retention of planetary heat. Warm oceans and air temperatures amplify the severity of hurricane hazards, increasing wind speeds, intensification rates, rainfall totals, and flood risk. This slide depicts the exact time when the eye of the storm is over Marsh Harbor. We will now hear from Dr. Holder Hamilton, who will give an account of scrambling during the eye.
Thank you, Dr. Hamilton, for a very informative start to this presentation. I am Dr. Nadia Holder Hamilton, and I was one of 4 physicians that survived Hurricane Dorian's wrath in September 2019. Pictured on this slide is the scene of my story. The Marsh Harbor Healthcare Center, one of 2 standing government structures during the passage of this powerful storm that made landfall in Marsh Harbor, Abaco, claiming hundreds of lives across the Bahamas. At this time, I will give you a glimpse of my experience of hurricane conditions lasting more than 24 hours during the front eye wall, the eye, and the rear eye wall. During the front eye wall, the on-call team led by Dr. Aswad were in the clinic while the rest of us bunkered down at the staff quarters, which are indicated by the red arrow. We had left our places of abode to be closer to the clinic in the event of the teams being unable to leave our homes after the storm to provide relief. The safety of these quarters soon became compromised with rising water, displaced shingles, and shattered windows. Communication was subsequently lost as well. Now here's the actual video clip that I sent in hopes of a rescue being trapped during this perilous time. Anyway, we just need emergency numbers called. We don't know if we're gonna move our stairs yet, but just in case the signal comes back in, we are still at apartment 2 on the right side, or the left side, the single room apartments. Water is coming in, wind is coming in. Things are all hitting the glass. The glass seems compromised, the roof seems compromised. We need help, please, thanks. As hope continued to fade, my husband, Dr. William Hamilton, and I made a final attempt to seek shelter. We left our damaged unit during the full force of the wind, in knee-high water, and with foreign debris seemingly aiming at our heads to reach our neighbor's unit. We kicked and we screamed to get their attention, and in fear of our lives, we returned to our damaged unit, believing with each howl of the wind, wondering which moment would be our last. This is the old doctor's complex with cars that were parked here, which got thrown all over. Trees got thrown all over. It's a total disaster. Windows blew out, a complete disaster. So this was the beginning of a drive filled with fear and uncertainty, and this was during the eye of Dorian. The two stars in the adjoining image show the route we took between the staff quarters and the clinic. There were moments of calm, as you saw in that video, mixed with intermittent gusts of unbelievable intensity, sometimes feeling as if the car would turn over. It was a daunting drive, but we were welcomed by the faces of our concerned team members once we reached the clinic safely. The clinic at this point appeared intact. It would be a safe haven, right? This thought, however, was short-lived. As I looked through the glass of the clinic's main entrance, a dump truck pulled up, and I watched in astonishment as the locals cascaded over the side of the truck and into the clinic, like a panicking stampede during the height of a Black Friday sale. Everyone, and I mean everyone, was scrambling for shelter. In essence, we had created our very own public health emergency. We at the Marsh Harbor Healthcare Center had just become a shelter in a matter of minutes for more than 1,500 persons.
Can this be? Oh, yeah.
And that happened in a matter of minutes. As we saw the desperation on the faces of those taking up residence, in that moment, we all knew what was happening on the outside of the clinic compound. Beyond what our eyes could see, we knew that it was cataclysmic. Though we were yet to see, we knew that we had seemingly survived, or so we would have hoped to survive, the most unpredictable natural disaster of our time. There was no communication with anyone outside of Marsh Harbor. We had no idea where the hurricane was in relation to where we stood in that moment. Were we over the worst? Or was this the calm before the storm? Regardless, we did what we were trained to do, and we got to work. Being on the front lines was not only riveting, but psychologically distressing during what we now know was the rear eye wall. The winds had returned to their previous state. The electricity was uncertain, and in certain moments we worked without it. We had little sleep. It was emergency after emergency while running on pure adrenaline. Here in this slide, you can see some of the physical injuries that we encountered. They went from deep lacerations. We had antenatal emergencies. We actually had a baby born as well. We had uncontrolled chronic diseases, gunshot wounds. We saw it all. in that short space of time. As we bring this presentation to a close, I would want to emphasize, however, though we can see the physical ailments clearly, on the mental health effects seen amongst two particular populations, the patient population and the healthcare worker population. And there was significant overlap in the acute phase. From a patient perspective, they looked for anyone who would listen to stories of family members being swept away from loved ones, as the water raged or as limbs were severed. Stories of bodies floating in the water while they waded and swam to the clinic for shelter. Patients recounted having to leave their children behind and children having to leave their parents behind. The accounts from the healthcare workers sounded eerily similar, with some nurses swimming in contaminated, debris-filled water for hours, with their children on their backs to save them from the surging floods, while others recalled the complete demolition of structures previously called home. So many of my colleagues lost everything, not knowing where their family members were to take care of those they had promised to serve. For me, they exemplified in the worst disaster that any of us had ever experienced: service before self. Most of us experience post-traumatic stress disorder, and more than 25 months later, we're still recovering. There is mounting evidence that climate change is making tropical cyclones more physically damaging and psychologically hazardous, while rendering island and coastal communities more vulnerable. The stronger, wetter, slower moving dynamics of storms, such as Dorian, are relevant for disaster planning and health systems preparedness to safeguard population health. As far as disaster planning is concerned, these storms are devastatingly destructive to built environment and pose overt threats to life and health. Lives were lost during Dorian because there were inadequate shelter accommodations to protect the populace. Island populations usually cannot evacuate away from a powerful storm. In order to optimally protect populations, communities must operate preventatively to develop comprehensive resilient plans. In our reference article, some of our recommendations are as follows: upgrading and enforcing strict building codes, retrofitting or constructing durable shelters with sufficient capacity to safeguard the population, prohibiting settlement in hazardous shanty towns. Communities should devise risk communications using reliable sources to present timely, trusted, life-saving information, and they need to enforce evacuation orders. Now, when it comes to policy for health systems, we realize the shortage of mental health workers. This was seen after Hurricane Dorian, and again throughout this current COVID-19 pandemic. An option to circumvent this is the use of task sharing to expand capacity. This can be done by mental health professionals, whereby they train paraprofessionals as staff extenders to provide psychoeducation in community venues and deliver evidence-based interventions with professional supervisors and supervision for survivors with elevated symptom levels identified through screening. In conclusion, the climate is changing, and climate change appears to be modifying the hazard profile of Atlantic hurricanes, as we saw previously presented by Dr. Hamilton. Hurricane Dorian epitomizes how climate-driven, stronger, wetter, slower moving extreme storms create devastating and enduring population health consequences, and specifically affects the mental health and well-being of communities of storm survivors. Mental health consequences are pronounced, they are pervasive and prolonged. Yet, disaster training of mental health professionals are a scarce resource. These trends have implications for disaster planning and health response. Disaster planning policy should emphasize resilience-focused prevention and mitigation strategies that minimize traumatic exposures and resource losses during impact. The community of Abaco has changed forever. The faces definitely look different. The landscape remolded and reshaped in the passage of this mega climate-driven storm. However, out of the ashes like a phoenix, I saw mental toughness and the true making of lifetime heroes who gave their community and their nation service worth the highest honor. Here listed are our references. Next slide, please. And on behalf of my co-authors and I would like to use this opportunity to say thank you and to remind us all that there is no planet B. We should all play our part. Thank you. And we will now entertain any questions that you may have.
Thank you, Drs. Hamilton and Dr. Holder Hamilton, for an excellent presentation. Certainly, I'm sure, an eye-opener for a lot of us viewing the photos, which some of us may have seen similar ones before, but certainly your account through the storm itself was certainly took us back to that time when we know that the country for your service and the teams and the other healthcare providers on that island. Excellent presentation. Are there any questions or comments?
Dr. Pinabuttle, I would like to comment.
Sure.
And just to say how much this is a flashback for me I was the doctor in duty for Hurricane Gilbert way back in 1988. And at Andrews Memorial Hospital, a private hospital there on Hope Road in Jamaica, when you started to show the devastation and you started to show the injuries to the human body, how vicious they could be, it just reminded me of the night of that hurricane, because the hurricane came at 6 o'clock in the morning and it stopped at 6 o'clock. The intensity of it, the highest intensity, stopped at 6 o'clock that evening. And then at night, folks started to come in with glass from their homes, imploding on whole families and cutting up a whole family up in a place called Jack's Hill in Jamaica, spending the whole night in darkness with a lamp and flashlight, suturing wounds, etc. It was really something. So I actually can greatly empathize, and I am so glad that you are on the mend. I'm really glad that you're on the mend, and I know it will take time, but our prayers will go with you.
Thank you,
Thank you,
Dr.
Frankson.
Dr. Knowles McPhee.
Good evening and great presentation. I remember as a child being awakened by my parents in the middle of the night because we lived in the valley to run to our relatives on the hills. I've been home immediately after Joaquin left, and I just came back from Abaco after 2 years of Dorian. I spent a month there. My question is, what what specific recommendations or adjustments would you give for our building codes and for our shelters? Because with my experience, I've found that our shelters are very inadequate. So what do you guys recommend?
Dr. Knowles, thank you for that question. So with reference to the shelters, I know for certain that I think one of our greatest challenges is that we, as a country, most of our businesses, shelters are on the coast. So, and we are relatively flat. And so if there is possible ways for us to elevate and or put shelters on stilts, because most of our neighbors in other Caribbean nations usually built with stilts. So in the event that you do have severe flooding, the water can then go underneath the structure. So that is one of the major recommendations. However, I am not certain of the other measures that have been in place, but I do know that the DRA that was implemented has done major work with many coastal and structural engineers with now fine-tuning our building codes.
Thank you for that. And one other question. Did you guys know of anyone, whether it was the island administrator or anyone responsible for the island, that would have like telecommunications with satellite phones? I remember with walking, the issue was they were sent to Nassau to be repaired and they never got them in time for hurricane season. We are very unique in our archipelagic makeup. And were you guys aware of any some form of communication, satellite phone, etc.?
So if I remember correctly, I do believe that our clinic administrator did have one. I think there were some challenges with that. However, how we were then able to subsequently communicate was that one of the NGOs that came in to Abaco on the first or second day, they had an entire setup with satellite phones. And that is how we were initially able to communicate with our families and some of our friends. Also, one of the telecommunication companies, they actually started a few hours into the storm where we were able to communicate. Initially, I was able to communicate outside of the Bahamas, which is why that voice note was actually sent to Barbados, to my Bahamian brother in Barbados, because I knew he would have a way to communicate with other Bahamians to get the word out. And he was able to put it into the live chat that was happening with the Prime Minister at that time to let them know that we were trapped and the doctors were trapped in the quarters. But the satellite phones were utilized. I do think there was an issue, if I remember correctly, with the government satellite phone, and there was some problems there, but we were able to use that from the NGOs when they were able to come into place.
Thank you so much.
Dr. Philippe, and then Claude.
Hello. Yes, I just wanted to commend Dr. Holder Hamilton and Dr. Hamilton, both just for their commitment to the Department of Public Health and their service during the time of Hurricane Dorian, in really leading the people of Abaco through that process. Really commend your courage, that took courage during the time. I also want to also speak about the opportunity that the UCARE Reform Project had provided, where Dr. Hamilton now is the first climate change health fellow for the Bahamas in the region. And because of this work, he was able to qualify, but also he is going to be able to really put some of the recommendations into practice and test it out in the Ministry of Health. So I really want to commend both of them for not only the courage of doing the work care providers need to be doing moving forward in regards to their preparation for handling disasters on the family island.
Thank you, Dr. Philippe, for that. So as far as healthcare workers are concerned, one of my deliverables for the fellowship is to have a project and symposium developed. And I think for us as healthcare providers and during Dorian, we realized that the mental health component was lacking. One, for how we took care of ourselves, and two, the type of mental health support that we could give to our patients. And so what I am interested in seeing is how we can continue to support mental health in healthcare workers by implementing psychological first aid, as well as skills for psychological recovery into our disaster preparedness plans for our clinics across the country.
Okay, thank you. And the final person's hands up can go ahead and ask the question or comment.
Hi, good evening, Dr. Hamilton, Dr. Holder Hamilton. Good evening, all. My name is Edward Claude. I would first like to commend you on the presentation. It is very informative. I noted that Dr. McPhee took my first question in terms of what further recommendations you would give in terms of preparing the country for further storms and further disasters. I'd like to piggyback on that question and ask, are there any conversations now being had in terms of implementing these measures? Because it's one thing to suggest and to have these conversations, but what conversations are being held now in terms of implementing these measures?
Thank you, Mr. Claude, for that question. And as I made mention, the DRA that was established right after Dorian has started to put some measures in place. But as far as where we are with that, I am unable to speak to. I know that NEMO is very heavily engaged in disaster preparedness for the country. And I know that the Ministry of Health sits on that as well. We have a liaison that gives our input to that body. But as far as exactly where we are, unfortunately, I can't speak to at this time.
And sometimes there's a difference between suggestions and implementation. So determining how far we are with actually making sure that these things not only are on the books, but that they're actually being implemented into the system can sometimes be difficult in the policy making arena. So it's definitely something that we will continue to advocate for, and hopefully we can see it implemented before the next natural disaster.
Dr. Moxie, this will be the very last brief question or comment for us, please, in the interest of time.
Yes, it's more for comment. Good evening. Well, thank you, Dr. Pinda Butler. My comment is about the UN Climate Change Conference coming up in Glasgow, COP26, which is going to bring together many people around the world. And I'm going to read this into the record. This is an opportunity to achieve pivotal transformational change in global climate policy and action. It's a credibility test for global efforts to address climate change, and it is where parties must make considerable progress to reach consensus on issues they have been discussing for several years. COP26 comes against the background of widespread, rapid, and intensifying climate change impacts, which are already impacting every region on Earth. And also COP26 comes against the background of the COVID-19 pandemic, with the urgent need to build back better for present and future generations to ensure a safe future. So this is taking place in Glasgow from the 31st of October to the 12th of November. And I'd like to encourage our local experts, the doctors Hamilton, to, I'm assuming they are participating at this level. And I'd also like to put in for the records the work of Dr. James Hospitalis, who is the inaugural executive director of the Caribbean Public Health Agency, who has formed an NGO called Earth Medic and Earth Nurse. And this is his sort of link to global climate change and global public health. And he has his website, earthmedic.com. And I'd like, if our group in the Bahamas has not yet sort of connected with him, I'd like to invite them to do that because we're looking at this thing regionally also. And, you know, he already has contacts and I think it's worth combining our efforts. You know, we're a little dot on the map, on the global map. So when we come together, we achieve more. So I just wanted to make that comment and also to congratulate the Doctors Hamilton on their amazing experience and their tenacity in the face of all this adversity that they had to go through. And thank God they're okay. You know, it must have been a rough time.
Thank you, Dr.
Thank you.
Moxie. And to that point, I actually have a meeting with Dr. Hospitalis next week to speak more on climate change matters in the region.
There you go. Awesome. Well, you're my students, so I'm proud of you all. My public health students. Well, you are Dr. Hamilton. I don't know, but you weren't in my class, were you?
No, I did internship. I did my 5 years at UE Mona, and then I did my internship in Barbados before I moved to the Bahamas.
Awesome.
So I'm sure you will have more offline discourse with the Hamilton. Sure. I'm sure that will happen. But again, we wish to thank them for an excellent presentation, most timely. Certainly, we all can appreciate that living in the Bahamas, climate change is certainly something that we all should pay close attention to. So thank you again for an excellent presentation. We're bringing this session to a close. We again wish to thank all of our speakers, our keynote speaker, Dr. Philippe, and our presenters who presented the resident papers, our DM recent graduates. We wish to thank you as well for all of your hard work. And thank you all who have participated and stayed with us throughout this second session today. We hope to see you all tomorrow, promptly at 6 p.m. and have a good evening.